Hello, everyone. This is Megan Barnard, and today I will be presenting my case study for the CMMS patient and application that I used for my qualification for our program. The patient that I'll be sharing with you today had a radial nerve palsy. So this is the initial eval, 4th of February. And this is how this patient's hand looked at our first visit. About 2 weeks prior to this, she had a fall in a parking lot, which resulted in a humeral shaft fracture. It was displaced and comminuted. She had lots of swelling throughout her entire limb. When she came to me on this day, she was wearing a fracture brace. At that point, she was still being considered for an ORIF. About 10 days after this initial eval with me, she went back to the doctor, and fortunately, she was in good enough alignment that they were able to allow her to continue healing without further surgery. But unfortunately, she had developed all of the swelling in her hand throughout her forearm. And in addition to the fracture, developed a radial nerve palsy. As I said, she was injured about 2 weeks prior to the CVAL. She's a 73-year-old female. And this first visit, she was limited in pretty much every way possible. Every single joint of that right upper limb was impacted with limited range of motion, significant edema. She was quite neglectful, almost like she had no ability to control the entire thing. It just kind of hung at her side. So she was referred to me by the trauma surgeon, and he wanted her seen 3 times a week. And originally, her orders were for elbow and wrist range of motion, and he wanted her put into the proper orthosis to manage the radial nerve palsy. So I provided her with a prefabricated tenodesis orthosis that provided dynamic MCP extension to 0, held her wrist in slight extension, allowed for her to grip and release. And PT was then brought in to manage the shoulder and the humeral fracture so that I, as her occupational therapist, could focus on the elbow on down to the hand and focus on that radial nerve palsy she had developed. So she was treated for the first couple months, as I said, 3 times a week. We really didn't make any significant progress. She continued to have swelling despite wearing compression gloves, despite manual edema mobilization. Everything just really didn't really improve with her. We got a little bit of improvement range of motion, elbow, forearm, but when it came to the hand, we were just not making any progress. It was kind of during these initial months that I was taking the CMMS online course. And so she was kind of who I had in mind the whole time that I was taking the course, thinking that this might be something really, really helpful for her. But I did have some reservations because I was concerned about the weight of the cast and kind of that history with that fracture being a little bit unstable. And so I presented it to the Facebook group, and the feedback that I got was that it should be okay. So here we are, April 1st, and kind of the problems that persisted were this pitted edema, which was just really intense with the metacarpals and throughout the forearm to the elbow. She didn't have the greatest home exercise compliance. She had a few different family members kind of helping her out during this period of time. And, some were better with her home exercises. But, she was just really kind of not super involved in the beginning. I think, obviously this was a really traumatic injury for her. She just kind of sat in a recliner all day and didn't want to do anything. Really developed a lot of neglect, made no attempt at even trying to move even the muscle groups that she had control over. I even felt like she had a little bit of cognitive limitations. She had difficult time answering really basic questions, recalling information. Certainly could have been an element of depression, but it was just kind of, it was kind of curious, that component of it, because as she got further along in her recovery, she definitely did become a better historian and a little bit more interactive. But at this point, she was fully dependent on whomever the caregiver staying with her at the moment was. She just really didn't make much effort to do much of anything on her own. So that last video I sent to her, her trauma surgeon, and had a bit of run around trying to get a hold of him and trying to convince him to let me try Sims with his patient. He, of course, had not ever heard of Sims and was really hesitant to allow me to immobilize this patient. He was very worried that she would lose wrist range of motion in particular. So we came to basically we negotiated and came to the agreement that he would let me try the cast for 2 weeks, but then he wanted it bivalved after that. Because he just wasn't comfortable with it. So these are her measurements the day that we applied the first cast. And you can also see here that I used some kinesio tape. She had a lot of tensioning, tightness of that skin from all that swelling that had been there. And so kinesio tape helped her feel a bit better. A little bit less pulling sensation. You can see with her radial nerve palsy how that wrist wants to pull forward when she tries to make a fist, and I come in here and give her a little bit of support. You can see that her digit motion is a little bit better, definitely leading with those IPs, but not much happening at the metacarpal joints. So we decided to proceed with making an intrinsic plus cast, and Robin was present on a Zoom mentoring session with me for this visit. The ULFI score that the patient completed was at 20% at this point. This is that first cast that I made, and definitely not my best, but it was a first attempt. But definitely some good lessons learned with this cast. You can see I definitely did not get very low to clear the distal palmar crease. So this cast, I looked at it with Robin and we kind of decided that it needed to come off and we needed to give it another try. So I did go ahead and remove it the following week. And surprisingly, when I did do some measurements to see where we were at, she had gained about 10 degrees of flexion at each of her metacarpal phalangeal joints. And so, at least there was, something that happened there that was positive. And I think we had a little bit of improvement in swelling. So even though that first cast was less than ideal, we still made a little bit of progress and definitely learned a good lesson moving forward. So about 2 weeks after that second cast went on, she was back in on the 10th, and per my agreement with her doctor, I bivalved her cast at this visit. She was going to be seeing him the following day, and he wanted to see her wrist. He was quite clear with me on this. So I went ahead and bivalved this cast. And unfortunately, not all of my videos loaded. So I'm going to have to back out and show you her range of motion once I did bivalve. But you can see she did make some excellent range of motion gains, 20 to 30 degrees at each of those MCP joints after this initial round of casting. So This here is her range of motion, right? Coming out of that cast.
Make your fist.
After I bivalved.
Pull it in tight, 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 tight. Good, and straighten it out. And into your fist. Good. Okay.
And you can see that I'm still having to maintain control over her wrist because of that radial nerve palsy. She still wants to pull into flexion. So that's why I'm giving her a little bit of support there. And because of that nerve palsy, that's also why she's not able to fully extend at the MCP joints because EDC was still out. So a couple weeks on from this brings us to the middle of May. And so one thing I forgot to mention back when I did bivalve her, we set up a schedule of 90% in her Sims orthosis, Sims cast, and 10% of the time in that tenodesis splint with all of that time inflection. It felt like we were losing some extension. And so because I wanted to make sure that that wasn't happening, I kind of peppered in a little bit of that other splint. And then here on the 18th, we were starting to see some trace active wrist extension, which was really exciting. And I adjusted her wearing schedule to 80% of the time in that Sims Intrinsic Plus cast and 20% of the time in the tenodesis splint. But this is her attempt at making a fist out of that visit. You can see still really poor extension actively at the MCPs. I could passively bring them all the way up, but this is her fist. Still needs a little support. I don't have to hold her quite as much to keep her wrist stable since she is starting to have a little bit of active extension. So this is where she was at. And again, another couple of weeks later, here we are, June 7th. And at this point, she was about 60% in her Sims or cast and about 40% in that tenodesis orthosis. And I was actually having her take everything off for hygiene and kind of, basic dressing things. And my reasoning for that was because she had so much neglect on this right side. And whenever she had either her cast or an orthosis on, she really was very not willing to move, not really willing to try to use that for function. And so I felt that it was holding her back. And so I wanted some engagement with that. Now, since she had been bivalved back in May, she had been participating again in therapy twice a week because we were also doing neuromuscular reeducation as well as therapeutic exercise to strengthen those weak muscles that she had. And since we were bivalved, we were able to do that. Here's her motion on the 7th. You can see I don't need to hold her wrist at all anymore when she's making her fist. She can do that on her own. And she's getting pretty decent motion. And so about a month after this, she had been kind of working through the weaning process of the intrinsic, sorry, that's supposed to say intrinsic plus cast. Sorry about that. And there was some vacation time in there. And so that's why a little bit of time passed. Now, her doctor was unwilling to allow her to go back into any full immobilization again. So again, we negotiated and did an active redirection orthosis just to kind of get those PIP, DIPs firing again. They had gotten a little bit stiff with all the focus on the MCPs. And so once her EDC was kind of firing again, which it was by this point, we went in here and thought this was good because this also gave her a chance to kind of push that extension with a little bit of resistance into the back of that cast. And so um, the schedule that we then followed with this was for her to wear the active redirection cast during the day. And then she was back in her intrinsic plus cast and she was wearing it overnight. Now, at this point, I went ahead and actually removed the palmar bar of her cast because it was starting to get in the way. She had gotten so much range of motion that she was now kind of running into that. And there really wasn't a way for me to cut it back further. So I just cut the whole thing off. And I actually then had two layers of the blue foam pad on the underside of the dorsal hood. So she had a lot of really, really great pressure, kind of pushing her forward into the end range of her MCP flexion. And that seemed to work really well for her. So about 2 weeks later, we started seeing some active radial abduction and extension, which was another really exciting milestone for us. And then a few weeks on from that, we sort of transitioned her from being in the active redirection cast all day to exercise only. Because again, her caregiver pointed out that with the cast, she was really mindful of not wanting it to get dirty. And so she wouldn't use her hand with it on. And so at this point, we kind of felt like it was holding her back. So we kind of changed our approach, decided to use that for exercise, but to do it, quite often. I think she was doing it. She was wearing it about 10 minutes of every hour, but making an effort to use her hand with her ADLs and trying to encourage just more activity in general. I did have her continue to sleep in the intrinsic plus cast. It was doing a great job getting her edema down. And so it made sense to continue that at that point in time. And so here's the end of August, and here's our final result. She did really great. Her swelling reduced significantly. She does still have some swelling in between those metacarpals, that we're still working on. It was so pitted and just so dense for so long. I think it's gonna just take some time to finish going down the rest of the way. But you can see that she's got pretty good, closure of her fist. So these are her ending measurements. And I went ahead and I put the original measurements there in yellow, just so you kind of have an easy reference of how each of these measurements changed. So, she did amazing. She, had almost full range of motion. Just a little bit at the end. I think she did have some pre-existing osteoarthritis. I don't know that she had a fully tight fist before her fall. So she was very happy with this result. She rated herself at 90% of her prior level of function, and her ULFI went up to 75. Let me just come over here because this was another video that wasn't loading for me, but I do want to show you what her range of motion looked like here at the end.
Ready? Show me your fist. Close, open. Good. Turn to the side. Close and open a few times. Beautiful. And then palm up towards me. Close and open. Beautiful. Thank you.
So yeah, like I said, we were really, really happy with her outcome. Her doctor was pleased. Her doctor was pretty surprised, pretty amazed that this wild idea worked. So hopefully next time I have a patient from him, he's going to be ready to let me start this sooner if it's necessary. So just to kind of summarize this case, this patient had 21 visits. of traditional OT prior to her SIMS application over about a 2.5 month period. And this was during the time that I was taking the course um, from April 20th till now, about 5 months or so, she's had an additional 27 visits of therapy. I know that sounds kind of high. I think if this was a more of a straightforward hand stiffness case, we definitely wouldn't have done this many visits. But after she bivalved in the middle of May, we resumed her 2 times a week because we were really focused on her therapeutic exercise and neuromuscular reeducation, just because of the particular diagnosis. And we wanted to support the muscle innervations as they were coming back. So I think that while it wasn't maybe the most traditional way to follow on with SIMS, I think in this case, given the set of circumstances, that's what needed to happen. And I think it worked well for her. I think her cognition, at least initially, was a bit of a factor, and part of that reason also why it required a little bit um, um, longer following on and number of visits, because there was some difficulty with carryover. I had to give lots of handouts and written instructions and take videos. And, fortunately, in this latter part, she had a caregiver that was a little bit more reliable and eager to make sure she was doing what she needed to do. Um, and, as she improved, I would say her mood, her cognition, all that stuff kind of came back in line. And she's been living independently again, like she was before her accident. So she's been living on her own, independently, making her own meals, shopping, driving, everything for the last month, and doing really well so far. She is still in PT for her shoulder, and I'm probably going to see her 1 or 2 more times. I think she's ready to be done, but she was not quite ready to go. She wants to stay with me through the end of the month. So we're just going to really focus on that home program, make sure that she's good to go and be independent. One thing that I also did that kind of deviated from the normal process was removing that palmar portion of the intrinsic plus cast. It was a bit of a gamble, but again, I think in this situation for me, it paid off because it really, allowed me to push her to her end range with the MCP flexion, and it was more comfortable for her, especially for sleeping. So I think that was something that worked in her case. My takeaways in the future, this type of situation comes up again. I would definitely want to start SIMS much earlier. I think really the only reason that it didn't start earlier was because I was in the middle of taking the course during that initial time I was with her. I also wasn't really sure if she'd be appropriate and how the cast would impact her fracture or the nerve injury, because at that point, there really wasn't much information about SIMS and using it with nerve injuries. My other takeaway is never lose sight of that distal palmar crease when you're making an intrinsic plus cast. Really, really important. Again, this was my first cast. And so I think I was, I had my brain in a million directions trying to make sure I did everything right and perfect. And I think I missed one of the most important things, but definitely a lesson learned. And every cast I've made since, I am quite cognizant of it. This surgeon definitely took some convincing. This is an older surgeon, kind of very traditional, very conservative gentleman. And so this was a really wild idea in his mind. And at the end of the day, we kind of had to negotiate, meet in the middle. I didn't have her in the cast as long as I wanted, had to bivalve earlier than I really would have liked. But I think it helped, given that we were still successful, because it really helped build that trust between myself and the surgeon. And he was able to see that this method really did make a huge difference and help this patient reach her goals. And I think moving forward in the future, he's going to be a little bit more willing to allow me to do this with other patients. One of my other takeaways was I think it was important to pursue active motion and strength of the wrist and digit extensors as that nerve reinnervation was occurring, and kind of balancing that with the Sims principles. Again, just because this was a case a little bit outside of what this was normally used on. Um, and also, you know, with consideration for the level of neglect the patient had from early on with that right upper extremity, and the way that anything on her hand made her really unwilling to use her hand. So I think it was helpful, just kind of balancing that out with kind of her needs. And for the stage of recovery that she was at as the muscle innervation was happening, kind of blending use of the cast, use of her tenodesis orthosis, as well as with nothing on her hand, and trying to encourage just engagement with that hand in the environment. I think this is a really good example. Unfortunately, we had a really favorable outcome of how SIMS can be applied successfully with radial nerve injury. It was a wonderful case to do for my case study. I'm very grateful this patient was not really willing, excited to do the cast, but she was a trooper and stayed with it, and she had a great outcome, and just really proud of her. I just want to say I'm so grateful for this training. I'm really grateful for this group and everything I've learned in this program. And I'm definitely more confident in my ability to make a difference for patients with a stiff hand. I mean, I think about if this had been a case that came across a year ago, and we probably definitely, I think, would not have the result that we did. So I'm so happy to have this skill and be able to take it forward to future cases. I just want to thank everyone. I've really enjoyed this group. I've enjoyed everybody sharing their stories, their successes, the things that they've struggled with. I think it helps us all learn and grow. And together we are unstoppable. So let's fix those stiff hands.